This talk yesterday while driving to Peterborough, I was like, what am I going to talk about? And this sentence that someone said recently at a conference to me, or not to me, to someone else while I was speaking, has stuck in my head. So I'm presenting something that's very much a work in progress, that is totally kind of a work in progress. So it could be a bit all over the place. And I'm going to be talking about some collaborative activism and research that is not just about me, but it's connected to a whole group of people I've been working with, one of whom is Colin Hastings, who's here. And so I was recently giving a presentation about our research project that we're doing, trying to look at where the blood of HIV positive people like myself goes once it's taken in a clinical setting. And when I was presenting at this HIV conference, a researcher who does research with our blood whispered to my colleague, "That's not blood, that's data." And so I wanted to talk about blood and data and blood as a text. I mean, in terms of my work, institutional ethnography, I understand it as being embedded in AIDS activism, through the work of Dorothy Smith and Gary Kinsman, and through Dorothy Smith's support of those individuals and the movement as a whole. And so I kind of continue that trajectory and work. And so this kind of to situate that. And increasingly today, HIV activism has becoming focused on molecules and the molecularization of life, which is a term that Bruce Braun brings forward. And I'll talk to you about what that means. But increasingly, the ways in which people living with HIV identify, and I'm happy to have a conversation with everyone as opposed to just me presenting here. So if you need me to clarify a term, if you're like, what is he talking about, whatever, have questions, just please interject. It doesn't need to just be me talking. But in terms of HIV stuff, for people who don't know, we are in an era where if you are living with HIV and you take antiretroviral medications under the supervision of a doctor, you can be rendered uninfectious, meaning you can't transmit the virus to anybody else. As a result of that focus, there's a fixation on people's viral load, a lot of attention to people's viral load. We might probably understand viral load in relation to COVID. How much virus is actively replicating in your blood. And so there's a whole identity focused on being virally uninfectious, of attention to the molecules in your body and the virus replicating. So that's kind of what this work is about. I'm talking about potentially blood as a text. So just to also highlight that what I'm talking about is situated in a activist context, specifically between Canada and the US primarily, also globally. And so this is a picture of the US CDC director, whose name I don't remember right now, and a group of people living with HIV advocating and calling for them to stop using molecular surveillance of people living with HIV, saying that we are clusters, we are people, not clusters. And I'll highlight what that means in a second. So molecular surveillance is a kind of surveillance that is used for many different virally transmitted viral infections. It can be done on COVID, can be done with syphilis, can be done with the flu. And it's about, I'll explain a little bit more what it's about. But often, and the ways in which it's talked about in relation to HIV, is that we are studying molecules, not people. And so the work that I've been doing is saying molecules are people, and people live in a social context, which is what Dorothy Smith always calls on us to remember. So just as a little bit of a primer, molecular surveillance starts with people's blood. And basically what it does is it takes the unique genetic sequence of the HIV replicating in your body, and it compares it to other people's genetic sequences, and it can tell a whole bunch of different things depending on how related they are to each other. They develop these basically like family trees of the virus, and they can say a lot of different things about the virus in relation to other people, and develop that all in the laboratory just by looking at the code developed out of your blood. And so it's important to note that in the context of, this is probably pretty small, apologies for my small, in the context of HIV, what this means is that someone goes to their doctor or to their nurse, and then their blood is taken for purposes of their clinical care management to figure out how their health is, how they're doing with their health. Is their medication resistant? All kinds of other things. And at the same time, one of those vials of blood, without people's knowledge, is taken by public health to do a secondary analysis to look at all these other things. And public health try to identify through genetic analysis, through comparing the viruses with each other and the sequences of the genetic code in the virus, they try to identify when the virus is actively replicating faster in certain areas than in others. So if they can identify where the virus is replicating fast through looking at the similarities in the genetic sequences, they identify what are known as clusters. And clusters are when transmissions are happening faster and they want to then intervene so that they can stop transmissions happening. So that's why we are people, not clusters, because people have been determined as being potentially part of a cluster, or maybe not known that they're part of a cluster. In the US, this has happened in that in rural communities where people are using drugs, clusters of people using drugs who are where HIV is actively replicating will be identified in the newspaper. There's been a number of instances where one instance which also coincided with actual other public health practices, where the name of the street where the cluster happened on was published in the newspaper to identify that this cluster was happening. Really quickly, and I'll move past the science in a minute, but so the molecular surveillance can tell us if someone's resistant to their medication, so they need a new medication, because it basically says the virus has grown around the way the medication is preventing the virus from working, and so you need new medication. It can also tell you your viral subtype, which can tell us what country you got HIV in, which including country of origin, which can also often be used to infer race of an individual. So, for example, in Canada, molecular or genetic information was used in a very famous HIV criminalization case to say that the type of infection that the women who were white got was related to a viral subtype only seen in sub-Saharan Africa, so they must have got HIV from a black guy. It can also tell us the timing of HIV in transmission, so around when the person got infected, because you can compare it to how the virus is actively replicating, so they can say all these things. And very creepily, they're trying to prove who gave HIV to who, so they can prove direction of transmission, because they can tell how much the virus has replicated over a period of time. Their one factor is they can't ever identify if there was like a person missing in between the two people, but they're trying to actively figure out how to do that. So just to give you a sense in terms of Dorothy Smith vibe of the whole thing, there's a whole disjuncture here with how this knowledge developed from people's blood is disconnected from people's lived realities. So this is what a series of clusters looks like. So this was from a study published in The Lancet in Los Angeles, from research done in Los Angeles on transgendered women. The purple, you probably can't tell from here, but the purple, whatever this shape is a transgendered woman. And the study published findings highlighting that transgendered women sleep with straight men. That was the big finding. straight identified men. So just a disconnect between the lived realities of anyone who knows a straight woman who happens to be trans. That's what's going to be happening. And so a series of people, including myself, responded to this paper led by trans women in the US, saying that not only was it disconnected from the lived reality of trans women, but also that these people didn't consent to have their blood objectified in this way. So we asked that question. And did the study identify the context of HIV criminalization of migration, and criminalization of sex work and drug use in the US? No, it didn't. And so the authors responded back to us in The Lancet and said, surveillance for numerous infectious agents, including HIV, is done ethically and without consent. The public good of HIV surveillance justifies this approach. And so in response to this, we did a number of different things, but called on the work of Gary Kinsman, who worked with Dorothy Smith, who asks us always to talk about who is the public in public health, and who is excluded from the public. And so here we can see that these researchers don't consider people living with HIV or trans women as part of the public. And so that's just the disjuncture context. And so as a result of this context, our research project, I have no idea how much time I have left, but probably, okay, I won't go too much longer. As a result of this context, I've been working on a research project trying to understand where our blood goes, because we don't know. And so we've been trying to map from the ground up where our blood goes. And so working basically using an institutional ethnography approach and talking to clinicians, lab technicians, the people who draw our blood, and also public health practitioners and public health policymakers, some of whom are willing to talk to us, some of whom are not. And just to provide a context, things have changed slightly, and we're on the precipice of a potential change, but Canada is still well known as a leading country in the world for criminalizing HIV in different contexts. And as a result of calls for reform and reforming legislation, there's a concern amongst activists that there will be a turn towards coercive public health measures as we move away from criminal legal measures. And so here's two examples, one from 2018. Apologies, I should not have put these people's names here. I'm just gonna remove that. But I'll just explain the two. One was, I just don't like to reproduce the people's names from media releases. I thought I had blacked it out. But one is from 2018, and it's from a trans woman in Edmonton who, it was a media release from the police, and the police said at the bottom of the media release, she is an active sex worker, and she has a high viral load and is not in treatment or under care. So we see the mobilization of people's viral load by policing authorities, and so that gets at kind of our concern. And then the other article was from the CBC from 2019 from a man who public health initiated essentially a manhunt against him with police because he was known by public health to not be taking his HIV medication.
Can I ask a question?
Yes.
In the case of the first person, how would they be monitoring her viral load if she was not under care?
Well, I think they made it's police a press release, and we can talk to Colin about how police press releases aren't necessarily grounded in reality, okay. But that I assume the assumption was probably made that she was not known to be in care, so they could assume that, which is not necessarily true.
No. And if the viral load is being monitored, she presumably is in care.
Yeah. So it was hard to tell what's happening there. And in the other one, public health authorities called the police and worked with the police to release that person's picture to the media, and then it launched like a manhunt against the person to mandate them taking HIV medication. And so what we've been trying to do with this study is, and which is still very much in its early days, is just to start mapping out how blood is mobilized, who has access to it, where does it go, what's happening with that. So we've got access to some documents from people in public health authorities, and one of our interview participants told us that the work of public health authorities is to check off boxes. And so they're all about checking off boxes, which then constitute risk. So there's a risk factor box at the bottom: sex with women, sex with men, injection drug use, HIV positive, using injection drugs, da 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 da. And so just learning about how also information about practices is connected to blood and what that means. And in Canada, this form of molecular surveillance that I mentioned is happening in some areas, not fully mobilized or deployed yet in Ontario, but is happening in certain research projects and is mandated in Quebec and BC. And so this gives you a map that we got provided to us from the government, from the Public Health Agency of Canada, of where our blood actually goes. So we had a good answer to one of our questions, but it gives us a map of that anyone's blood who's tested and they want to get molecular analysis done, all of it goes to BC and to the Public Health Agency of Canada, and then is shared in various different ways. I think I'll just skip over some of this. But I think just bringing it back to Dorothy Smith's work, the thing I was just going to show you is a study that's done on the racist ways in which this stuff is mobilized. But Dorothy Smith talks to us, and we talked earlier about, and Aaron, you talked about this, about what constitutes a text, what is a text, and is a text been so broadly articulated that it becomes nothing at this point. But I think the ways in which I'm viewing it or thinking about it in relation to this is that text is a material thing which can be taken up ideologically, and it's a point of entry. Texts for Dorothy Smith were where the actual can become the conceptual as translated into a form of institutional document, where the institutional document or the text is reified from the experience in which it's created. And so we just see that really, really happening with these digitized aspects of blood. And so wondering, and I'm just kind of thinking through our connection to this project and Dorothy Smith's work, if this is the right approach, and just kind of trying to think through if thinking of text, blood as a text, is the right way to go. I also like this quote from DeVault and McCoy's book. Note that any kind of material, replicable document or representation that can be stored, copied, produced in bulk, or distributed widely is a text. And so interestingly, to think about with these genetic sequences, they're created, they're shared widely, shared in banks of genetic sequences. My genetic sequence is probably in BC, who then share their genetic sequences with genetic sequence, like genetic sequence banks at Stanford University. There's one in Los Alamos, Texas, and there's a global one happening in Geneva. And they can be open for people to share and look at and examine. And they say that they're anonymized, but it is a unique genetic sequence connected to part of my body. So, and just quickly, I guess there's some questions here about bodily autonomy in relation to this. What does it mean to have part of your body taken away from you, turned into code, and then used to produce knowledge about you without your consent? Information sharing across institutions is a concern, and we're just working on an approach of, like, we talked about talking back. I mean, we're talking about surveilling a system that surveils us. This is what this research is kind of all about. And that's it.